Welcome to the program entitled Improving Clinical and Cost Outcomes in Hyperkalemia. This program is supported by an educational grant from RLIPSA Incorporated and is provided by North American Center for Continuing Medical Education, LLC, an HMP company. My name is Jeff Dunn. I am Vice President for Clinical Strategy and Programs and Industry Relations at Magellan Rx Management. I am located in Salt Lake City, Utah. I'm joined today by Dr. James Matera, who is the Medical Director for Population Health at Centra State Medical Center in Freehold, New Jersey. The learning objectives for this program are listed here. By the end of the program, we should be able to quantify the clinical and economic burden of hyperkalemia and the impact of suboptimal management on outcomes, support protocols to enhance the identification of patients with or at risk for hyperkalemia, evaluate recent potassium binders in terms of safety, efficacy, labeling, dosing, and role in acute, subacute, and chronic hyperkalemia management strategies, and finally, integrate the latest clinical and pharmacoeconomic data into evidence-based formulary decisions and benefit design. So let's get started with a quick overview of hyperkalemia. Hyperkalemia, here in the middle, as demonstrated by the red circle, is caused by a redistribution, decreased secretion, or increased intake of potassium. It is common in diabetes. It has increased prevalence and risk in CKD and AKI due to decreased GFR, tubulointerstitial disease, and a number of other things. And it is exacerbated by cardiovascular disease. Hyperkalemia is a potential adverse effect of many cardiovascular drugs, and we will discuss this in more detail in a minute. Hyperkalemia is associated with significant economic burden. Some statistics include, in commercially insured patients, the per member per month costs were 15 times higher in patients with CKD and hyperkalemia than in the total or normal population. The per member per month treatment costs were 5-fold higher in Medicare patients with CKD and hyperkalemia than in the total Medicare population. Hospitalization rates are much higher in patients with CKD and hyperkalemia than in those without hyperkalemia among Medicare patients as well as those with commercial insurance. The mortality rate was more than double in Medicare patients with CKD and hyperkalemia than in patients with CKD but without hyperkalemia. And currently, and importantly, few treatment options and no specific guidelines are available for the treatment of hyperkalemia in patients with chronic conditions. And we'll talk a little bit more here in a minute about the clinical consequences and mortality associated with hyperkalemia. As mentioned earlier, many common medications can cause hyperkalemia, and many of these medications are needed in at-risk populations in order to improve outcomes. Here on the left, we have listed all of the different classes that can cause hyperkalemia. The two most familiar are probably the ACE inhibitors and the ARBs. Examples of those medications are lisinopril, captopril, losartan, irbesartan. These act or work by inhibiting the conversion of angiotensin I to angiotensin II. And then we have others on here, including NSAIDs, COX-2 inhibitors, digitals, etc. But the point is that many widely used drugs can cause or exacerbate hyperkalemia. A study by Chang and colleagues showed the relative risk ratios of developing hyperkalemia of these commonly used drugs broken out by potassium levels. On the left, we have potassium levels greater than 5. On the right, we have potassium levels greater than 5.5. But we can see that the relative risk ratio of developing hyperkalemia significantly increases with all of these drugs, with the exception of diuretics. The clinical manifestations of hyperkalemia include severe muscle weakness, electrocardiographic changes, conduction abnormalities, arrhythmia, reduced urinary acid secretion, and death. And we'll show that here in a minute. Now, interestingly, the RAIL study in the late 1990s led to a significant increase in the use of spironolactone. We can see there was a significant spike in 1989, 1988, 2000. And by correlation, hyperkalemia also increased at this time point. So we see here in the increased utilization of spironolactone occurred, there was a 2 to 3 times increase in the rate of admissions for hyperkalemia. What happens after a diagnosis of hyperkalemia? Here there are a number of different outcomes. The first is we typically see an increase in emergency department visits. You can see that as it relates to a potassium level greater than 5 or 5.5, it is significantly higher than the control rate. There is a significant increase in the use of SPS, or sodium polystyrene sulfonate, which is prior to the newer drugs entering the market in the last little while. This was the standard of care, but it has significant adverse events. So there was a very, very large unmet need in terms of how we could manage hyperkalemia through the use of medications. And then importantly here we see on the bottom 4 or 5 lines on this chart, there is typically a discontinuation or a decrease in the use of ACE inhibitors or ARBs or potassium-sparing diuretics. All of these actions negatively affect outcomes and quality metrics. These drugs need to be maximized in order to realize cardiovascular benefit. So what is hyperkalemia? Hyperkalemia is defined as serum potassium levels greater than 5 milliequivalents per liter. The incidence of hyperkalemia in the United States is 2.5 to 3.2% of the population with severe risk factors, of which chronic kidney disease is the most common risk factor. The RAS inhibitors often cause hyperkalemia. Their use for other disease states can be limited due to this adverse effect, which is the problem. We want these drugs being used for their cardiovascular benefit. The Milliman analysis of 2014 Medicare 5% sample data and market scan medical claims data outlined patients with CKD by severity level with and without hyperkalemia. Here the different colors are the stages. The left 2 bars are Medicare, the right 2 are commercial, and then it's broken out by with hyperkalemia and without hyperkalemia. So the point here is that hyperkalemia occurs across the CKD spectrum. The same analysis reported the per patient per month cost of hyperkalemia. And again, broken out by stage in Medicare and commercial with hyperkalemia and without hyperkalemia. I'm not going to go through all of the numbers, but the point here is that CKD costs are significantly higher in the presence of hyperkalemia. Hospital admission is also increases with hyperkalemia. This here again is broken out by Medicare on the left, commercial on the right. And we can see the numbers, or the colors are associated with the number of admissions. So hyperkalemia causes an increase in the number of hospitalizations or hospital admissions, and subsequently incurs a significantly higher cost due to that hospitalization. And this is especially true in the presence of CKD. So this slide is a crucial slide. This is the crucial point. So hyperkalemia significantly increases the risk of death. We see this is a U-shaped curve based on potassium levels. As potassium increases above 4.5, 5.0, 5.5, there's a significant increase in the rate of in-hospital events. Interestingly, hypokalemia also causes an increase in hospital events and mortality. So we really need to closely identify, treat, and monitor patients with hyperkalemia. There is also a link between CKD and heart failure. A meta-analysis of 57 CHF trials that encompassed more than 1 million patients found that CKD was highly prevalent, occurring in 32% of patients with CHF. This leads to increases in mortality rates and hospital admissions. And going back to the medication issue, this is thought to be related to underdosing of the RAS inhibitors, or even not prescribing them to begin with due to the adverse effect or perceived risk of hyperkalemia. This in turn leads to a 2-fold increase in the 30-day mortality or readmission rate, and hyperkalemia was a major component in the decreased use of RAS inhibitors. So at this point, I will turn the presentation over to Dr. Matera.
Thank you, Dr. Dunn. Excellent overview of hyperkalemia and of the cost implications there. As we all move into the value-based medicine world, that becomes increasingly important because our reimbursement, hospital reimbursement, physician reimbursement, is going to be tied to a lot of our outcomes, reducing readmissions, which are very common in these situations, and trying to maximize our benefits. We know, and I'll show a few slides in a moment, how important ACE inhibitors and angiotensin receptor blockers are in various disease states, and as a nephrologist, I see the gamut of that. One of the things we also see in heart failure, as I go to the next slide, is that many times people with heart failure on multiple drugs, such as aldosterone agents, ACE inhibitors, digoxin, angiotensin receptor blockers that can precipitate hyperkalemia, and many times that leads to a very limited use of these medications, despite the evidence telling us that these medicines are actually very beneficial for our patients. This goes back even to 2000 when the HOPE trial, the Heart Outcomes and Prevention Evaluation Study, looked at ramipril versus placebo in about 9,000 patients. And the results were pretty stunning, and that kind of led also to the advent of maximizing these medications in congestive heart failure. We saw a reduction in death overall of 16%, a cardiovascular death in particular of 26%, a decrease in myocardial infarction and in heart failure symptoms as well. This was followed up a few years later by the European trial on reduction of cardiovascular events using the agent perindopril, not a very common one in the United States, in patients who had stable coronary artery disease. And this was also a large study, about 12,000 patients, and they again found a 22% reduction in myocardial infarction. Interestingly enough, they didn't look at heart failure in this group of patients, and other studies that were done in this meta-analysis showed that the results did not correlate very well in coronary disease, but patients with CHF had a persistent benefit from the use of RAS agents. So this brings us to our large dilemma. We have a few dilemmas in these type of patients, especially chronic disease patients, chronic kidney disease patients who have congestive heart failure. Many times we'll use diuretics and we'll see that their creatinine goes up, so our tendency is to scale back on the diuretics, which makes their symptoms get worse, and then we increase the diuretics in this very vicious circle. Same thing can happen with hyperkalemia. So our decision or our dilemma is, do you go ahead and prescribe the RAS agents and allow hyperkalemia? And we've seen on previous slides that Dr. Dunn just showed, that can bring in a whole slew of adverse outcomes, including increased hospitalizations, increased mortality. So not a great idea to allow hyperkalemia. So what we've had to do is avoid or discontinue the medications, even though we know that they're beneficial, and that's also not a good thing. So what do? This ends up leading to suboptimal outcomes if the medications we need have to be stopped, adjusted, or augmented, especially in use of the RAS inhibitors. So many times we don't see our patients getting the benefit. This slide shows that use of RAS agents in chronic kidney disease, according to the Kidney Disease Global Outcomes data, is recommended in one of their guidelines. And what they say is they want us to use ACE inhibitors or angiotensin receptor blockers in CKD, and we want to use them at the highest doses tolerated. In chronic kidney disease, we see many beneficial effects outside of patients who have heart failure. But also in their guideline, it says if hyperkalemia develops, we need to decrease or discontinue these medications. And again, this is a little counterintuitive to what we know can be beneficial effects of these medications. So this is a study that just came out this year. It's a small study, only about 115 patients, called the Tourmaline study. And what it showed, and we'll talk a little bit more about Patiromer in the near future, that showed that this medication to lower potassium was similarly effective with or without food, but also whether or not you were taking RAS agents. So people who had hyperkalemia, average in this study was about 5.5. Whether they were taking RAS agents or not, they came down, 84 to 85% of the patients achieved a serum potassium between 3.8 and 5.0. So this tells us that the RAS agents, in addition to a medicine that can be used to combat some of the hyperkalemia, can become a factor in our armamentarium again, especially with the data that we have showing that they're so successful. So what have we done in the past to treat hyperkalemia? Classically, we've been dividing this type of treatment into three goals. Number one, the most important is to stabilize the membrane, especially in very significant hyperkalemia with EKG changes. and that's done with calcium gluconate salts. Then we want to redistribute the potassium to kind of get it away from the membranes as well. And we've all had that scenario where we give insulin, dextrose, and calcium in the emergency room. And some people have also advocated use of beta blockers to help redistribute the potassium, but focus on that word redistribution. It's only moving it around. We have to then eliminate it. And some of the medicines we've used in the past are alkalinizing agents like sodium bicarbonate, loop diuretics, which can have a forced kaloresis, and then the sodium polystyrene, which we alluded to and we'll talk a little bit more about, has kind of been the only agent we've had available to us. But now we have some newer agents which will change the scenario and the landscape of how we treat hyperkalemia. So sodium polystyrene sulfate has been approved in 1958, a long time ago, and this was before design-controlled trials were required. And I would venture to say that sodium polystyrene would have a very difficult time being approved today with the current requirements and review processes. There's actually no convincing evidence that SPS increases fecal potassium losses in experimental animals or humans, and there's really no evidence that when you add sorbitol, which brings in a whole other slew of adverse effects, to the binding resin, increases its effectiveness. And there is a concern that the SPS may not be effective without the osmotically active agent sorbitol, which again can lead to some problems, and that includes intestinal necrosis. Back in 2009, the FDA actually issued a warning on SPS, saying that cases of intestinal necrosis, which had been fatal, and other serious gastrointestinal events like bleeding, ischemic colitis, and even perforation, have been reported in association with SPS use. Most of these cases also had the concomitant use of sorbitol, which seems to be one of the motivating factors for these GI adverse effects. And these were present in many of the cases, and the risk factors included prematurity, history of intestinal disease or surgery, hypovolemic patients, and those with chronic kidney disease and failure. So they don't recommend the use of sorbitol for this agent. So we clearly had a gap in care here in trying to treat hyperkalemia, not only as a primary disease state, but as a secondary disease state from some of our medications. And this, we thought, would allow us to use RAS inhibitors in disease states like CHF and CKD, where they have a known benefit. We know that the safe use of sodium polystyrene sulfonate is very questionable and not a great option, although one of the few that we had in the emergency room. And so there was a need for development of new agents, two of which have come out, Patiromer and sodium zirconium cyclosilicate. And this actually may allow us then to use and maximize the RAS agents in the above disease states. And that makes sense when you think about it. We want to try to use the medicines that we have that are known to have positive effects on disease states in order to lessen the risk, improve quality outcomes, and improve patient outcomes as well. So one of the first studies to come out looking at this was the OPAL-HK study, and that, again, we know that the RAS agents are excellent agents to use in clinical situations, and they span the gap from heart failure, renal disease, diabetes, and actually very good antihypertensive agents. Hyperkalemia often leads to lowering the dose or stopping the medicines altogether, abating the safety and good outcomes that we see for this. So OPAL-HK was designed to evaluate the safety and efficacy of Patiromer in patients who had chronic kidney disease. They looked at stage 3 and 4 CKD patients whose potassium levels ranged from 5.1 to 6.4 and were on a RAS agent for 28 or more days, and they divided this study into two phases. Phase 1 was what they called the initial treatment, and there were about 240 patients in that. And they treated with different doses of Patiromer based on the potassium. Mild patients got 4.2 grams of Patiromer twice a day, and moderate patients who were above 5.5 received 8.4 grams of BID. Then they went into a phase 2 or a withdrawal where they were randomized. 107 patients were included, and they had serum potassium greater than 5.5 at baseline, and we're down to 3.8 to 5.0 at the end of phase 1. They divided those into the placebo group and the Patiromer group, about 50 patients each. So what we saw in the phase 1 trials is we were able to have about a 0.65 decrease in milliequivalents per liter in potassium in the mild group, and over a 1.23 decrease in potassium in the moderate to severe group, with an overall of about 1.01 milliequivalent per liter decrease. Moving into phase 2, what we saw is the reduction in potassium from the end of phase 1 to week 4. In the placebo group, the potassium went back up, whereas in the Patiromer group, it stayed stable. So the between group difference was about a 0.72 value, which again was clinically significant and shows that Patiromer can help keep the potassium under control. So what about the use of diuretics? We spoke earlier about diuretics being one of the mainstays of therapy to help reduce hyperkalemia. And when you use Patiromer with or without diuretics, it doesn't abate the effect. The effect remains the same. So you can look at the patient starting at about 5.6 in this graph and going down into about the 4.6 range, whether or not they had use of diuretics. Also a very good component because we know most of our patients have to also have diuretics, and the diuretic and the Patiromer combination don't seem to drive the potassium too low, as we also saw in a slide before, is not very good as well on that U-shaped curve. So what about the results of the OPAL-HK? The strengths were that the patient population, about 57% had diabetes, and they were in stage 3B chronic kidney disease. They had a wide variety from mild all the way up to severe potassium levels, and we do know that Patiromer is now approved by the FDA. The weaknesses were, in this particular study, there was no placebo or active control in the initial phase. But the conclusion said that Patiromer can reduce potassium levels and, importantly, maintain normal kalemia in patients with CKD on RAS inhibitor therapy. So the possibility that we can continue these agents safely when we have a medicine to help control the potassium effect. So what is Patiromer? It's a cross-linked synthetic polymer which actually exchanges calcium for potassium in the GI tract, where SPS is a sodium exchange resin, and this is done primarily in the colon. The advantages when you compare it to SPS is it is a calcium counterion. There's a low swelling ratio, which talks about the effect of fluid movement into the colon, and it actually binds a fair amount of potassium, 8.5 milliequivalents per gram, and they use significantly less sorbitol. So the interesting thing is, though, although Patiromer is not approved for the acute setting, it can be used in the subacute or adjuvant setting once other emergent treatments have been started, and that should also help us in the future as we treat hyperkalemia. So adverse effects, we're all concerned about these in our patients. Interestingly enough, the most important one that we see in about 7.6% of patients is constipation. And then also on the counter effect of that, 4.5% of diarrhea. You do have to watch electrolyte abnormalities. This can precipitate some hypokalemia in about 4.5%, and hypomagnesemia as well. And this also becomes important if your patients are on proton pump inhibitors, which can exacerbate hypomagnesemia. So important to pay close attention to the electrolytes when using these agents. A second agent called sodium zirconium cyclosilicate is a lattice type of medication that selectively attracts potassium. And what it does is in the entire GI tract, not just the colon, it'll exchange potassium for sodium and hydrogen counterions. This is now FDA approved, and we're going to talk a little bit here about the HARMONIZE trial, which the primary endpoint was a comparison of mean potassium levels between a placebo-based group and each treatment group during a period of 8 to 29 days. And these were patients, this was an outpatient trial, where they had 2 consecutive potassium levels over 5.1. So this is a little bit of a busy slide, but again, in ambulatory patients with hyperkalemia, administering sodium zirconium cyclosilicate reduced serum potassium levels to the normal range within 48 hours. In the randomized phase, compared with placebo, giving all 3 doses, 5, 10, or 15 milligrams of sodium zirconium cyclosilicate, resulted in lower potassium levels, and a higher proportion of patients had a normal potassium level for up to 28 days. So you can look at that based on the different colors. You have the placebo up on top, followed by the different doses of sodium zirconium. So again, a good study to show that this can be an effective agent. So again, we see a lot less constipation in this one than we did in Patiromer. And also, again, you just have some of the issues that you can see with electrolytes, but most of them were pretty well under control, with about a 1.6 being the max for diarrhea. Interestingly enough, also, the hypomagnesemia has not been reported here, but I would still want to keep an eye on that as well. So the role here may be in the more chronic management of hyperkalemia, especially in patients with comorbid conditions and those with the need for continued RAAS agents. There's also a potential role for the management of acute hyperkalemia. This does have a 1-hour onset of action, but the studies have looked at it over 48 hours. So these medications are not approved for acute use for hyperkalemia at this time, although I think they can be useful adjuncts. So a few final thoughts before I turn it back to Dr. Dunn here. We've been very clear in showing that hyperkalemia limits the use of optimization of RAAS agents, very important medications in patients with CKD and CHF, and this adds costs while increasing morbidity and mortality, counterproductive to everything we're trying to do with our patients to improve quality of care. And this is likely due to the hyperkalemia itself and thus the limitation of these agents. There's been a widening gap that's emerging between guideline-recommended therapy for RAAS agents and real-world experience, as we end up with clinical inertia, and we end up altering or adjusting our medications in view of an adverse event. Patiromer has been shown to be well-tolerated and effective for the treatment of hyperkalemia in chronic kidney disease patients with hypertension and other comorbidities maintained on RAAS agents. And this has been alone or in conjunction with other agents like diuretics. And our second agent, sodium zirconium cyclosilicate, has also been shown to be effective in reducing serum potassium to normal levels within 48 hours and the ability to sustain those levels for up to 21 days at all 3 doses. And it has a very similar profile, in fact, a little bit better from some of the issues like constipation and hypomagnesemia with Patiromer, but again, I would still monitor those patients. So with that, I'm going to turn our presentation back to Dr. Dunn for some managed care thoughts on hyperkalemia. Dr. Dunn?
Thank you, Dr. Matera. That was an excellent presentation. It is an exciting time with newer agents now available that are effective and safe, and we haven't had anything in a long time, and there was a huge unmet need. So thank you very much for that.
Absolutely.
Shifting gears, the pharmacist should have a significant role in the management of hyperkalemia. Pharmacists can do a number of things. They can identify patients at risk for drug-induced hyperkalemia and opportunities to manage chronic conditions when they are at risk for hyperkalemia. They can also counsel patients to ensure that they have sufficient understanding, knowledge, and skill to follow their regimens and monitoring plans. This can be done through programs like care management, case management, medication therapy management, etc. Pharmacists should also seek ways to motivate patients to learn about their treatment and be active partners in their own care. What we've seen historically through our programs is that we can't tell a patient what to do. That's not effective. We need to bring them into the plan, engage them, and if they understand it and are actively working on this towards the same goal, the outcomes are going to be much better. Pharmacists can also engage other stakeholders, including dietitians, regarding patients' diets to assess for sources of potassium. So the key is I think pharmacists are in a unique role or place to coordinate with all of the other care providers that interact with our patients. The challenge for pharmacy and therapeutics committees or P&T committees when balancing the formulary issue and costs with care management and case management, so taking the population tool of a formulary and applying that to an individual through care management or case management, includes finding the right drug benefit design to provide appropriate access for medications. So when we have these new medications come out, making sure that we have them appropriately placed on our formularies. Other challenges include providing utilization data essential to provide continuing care to members. We should encourage a chronic care treatment approach This includes primary prevention, so using our data and tools to identify patients who are at risk for hyperkalemia, but then also using the same tools to treat patients who actually have hyperkalemia. Other challenges include publishing and distributing evidence-based treatment guidelines. Guidelines are tricky when it comes to formulary. Again, guidelines are very broad, and they usually don't get to the granular level of telling us which drug should be used for what patient. We should reward best practice. This can be directed to patients and providers. When we do it to patients, this includes things like benefit design. When we reward best practice with providers, that could include things like lowering restrictions, like for example, prior auth criteria, or reimbursing them higher, reimbursing them for outcomes rather than fee-for-service. Another challenge is integrating the P&T review process. A lot of payer organizations separate clinical and financial. So the key is tying efficacy, tolerability, and safety with financial data. Here, the point of this is we should be focusing on value and comparative cost effectiveness, not siloing clinical and financial issues. Some other challenges for managed care include using guidelines to guide treatment. Again, like I said, the challenge is that guidelines don't always translate very well to a formulary. They're very broad, and they don't tell us which drugs should be preferred or which drugs should be used first typically. Another challenge is understanding what is going on with a specific patient. This includes the affordability issue, medical literacy, lifestyle changes. This is probably a place for medication therapy management services. And then there's another question of how do we use things like quality of life and patient-reported outcome data in our formulary or benefit design. We typically don't know how to value those types of things. We don't know how to pay for those kind of things. Another challenge is adherence. Whether we're talking with medications used to treat hyperkalemia or even the RAAS inhibitors. Anything that is potentially chronic has an adherence component or risk. And the importance of adherence is when we're paying for things, we want to see the outcomes based on our investment in paying for medications. Another important challenge is how we improve the information flow to clinicians. So again, payers, like pharmacists, are in a unique and key role. Payers have access to the most data. We know what patients are doing. We know what providers they're seeing. We know if they're taking their medications or filling their medications. We know what they're doing. So we should be able to lead and coordinate a better effort for interacting with our patients, but then also communicating these interactions with the other people that are working with our patients. Typical formulary utilization controls include things like prior authorization. This potentially includes molecular testing requirements, not necessarily applicable to hyperkalemia. Step therapy is another commonly used utilization control, which this is typically done electronically, where we require the use of a preferred agent before a non-preferred agent. Formulary design is extremely important and is a huge issue right now. And benefit design includes concepts like open versus closed formularies, how many tiers we have. For example, do we have multiple specialty tiers? Do we put a drug on a specialty tier or a traditional tier? And then the use of copay versus coinsurance benefit designs. And all of these, though, need to find a balance between access and affordability, and they need to be appropriate. Unfortunately, due to cost trends, we are seeing a significant increase in the use of coinsurance and deductibles, and this, I think, is having a negative impact on adherence and outcomes. So we need to be very, very careful and make sure that our benefit designs are appropriate. I mentioned medication therapy management a while ago. Patients who will benefit most from these types of services include those who have not reached or are not maintaining the intended therapy goal, those who are experiencing adverse effects or drug interactions from their medications, those who have difficulty understanding and following their medication regimen, those in need of preventive therapy. So medication therapy management also, in addition to looking at claims and historical data, looks for gaps in care. And then other patients who will benefit from MTM include those who are frequently readmitted to the hospital. So MTM looks at medication history, claims data, and looks for patients who are using a lot of resources, who are inappropriately using medications or even have gaps in care, and then intervenes with the patient, provides a better plan, and then communicates that plan to the other people, including the providers who are involved in taking care of those patients. So how do we do this? typically, resources are always scarce within a payer organization or even in a provider's office. So this includes people, time, facilities, equipment, knowledge. Many medications are expensive. Rarely now in the current environment is there a positive OR with these expensive medications. And more, drug costs are driving total cost. So as we've seen in the last 4 or 5 years, a doubling of what we pay for medications in this country, more and more of the total cost of care is shifting towards medications. So we have to be so one way we address this is by using pharmacoeconomic evaluations. They help us make the decision process more explicit and by providing comparative value propositions. And so that's, I think, the goal of combining clinical and financial is we really need to find comparative value, and value is typically defined as outcomes divided by cost. Comparative effectiveness provides meaningful comparisons between different interventions instead of comparing those interventions to placebos. The CE also offers the advantage of pooling findings from various studies and grading the quality of evidence, and it educates payers and providers about different strategies and interventions to treat and monitor patients in the real-world setting. Comparative effectiveness really helps us when we don't have head-to-head studies. So typically what we do, at least from a payer perspective, is when we're evaluating drugs that don't have head-to-head studies, we will look at similarly designed studies, and then we look at the difference between the drug and placebo. And then we divide into that delta the net cost. And what that provides us is a comparative outcome, or cost per outcome, and that is a better way for us to make indirect comparisons than using more subjective indirect comparisons with placebo-controlled studies. Comparative effectiveness does have some limitations, however. For example, too many trials compare active agents with placebo, so that really makes our analysis indirect, and that's a challenge. Drugs shown to be equivalent for an average group of patients does not necessarily imply that they are equivalent for all patients. So again, it gets back to this concept of how can we apply population data to a specific patient, and is that appropriate? Another limitation is the broad scope of research makes quality ratings even more important, and we must place a high value on effectiveness and internal validity. So it begs the question of how good are we at this process? Do we have the internal resources and knowledge to do the appropriate comparative effectiveness research? The hyperkalemia drugs aren't inexpensive. They're not specialty medications, which is a great thing, but they're not inexpensive. The Patiromer WAC, or wholesale acquisition cost, is about $27.36 per packet. This is flat priced, so it's regardless of strength. SPS is available generically, which is a good thing, and it's a multi-source generic. So the average MAC per 15-gram dose is really just $1.57. So it's a lot less expensive, but as we've seen in the previous presentation, it has some serious potential adverse events. And then sodium zirconium cyclosilicate WAC is about $21.83, also flat priced, so regardless of strength. So the comparisons here are really the WAC costs and then net. So this is between the two branded agents. So this does not include rebates. This is the WAC cost, so not net cost. And typically when we're doing our financial evaluations, it is a net cost evaluation. So what's the case for access for these new agents? We have to ask a couple questions, or a few questions. First is the newly released product or products superior to the already improved products? And I would say if we look at the two new agents versus SPS, the answer to that is yes. The previous standard of care had some limitations, but the newer agents are branded. They're more expensive. So we really need to look again at the value proposition that they bring to the table. We have to answer the question, what is the true cost? Like I mentioned, WAC is not true cost. It really is net. So rebates play a role in that. So net cost is the cost we should be looking at. We should be looking at resource utilization. So what offset or what medical benefit do these drugs give us? And we typically focus on direct resource utilization, things like emergency room visits or hospitalizations. And then how do we value those? Is the offset, do we get more benefit or offset of avoiding these types of resource utilization by paying for the drugs, or the drugs more expensive than what we're offsetting? And then this also begs the question of how do we value this if we're a PBM, for example, and not paying medical claims for emergency room visits or hospitalization. The data is still important when we make our formulary decisions, but we're not paying for medical claims. Another question is, how do we put in place any utilization controls? So do we use things like prior authorization or step therapy? And there it really comes down to the question of what is the risk of inappropriate utilization of these agents. And then lastly, if all things are equal, how do we value the patient-reported outcomes? Does that change our analysis? And then again, how do we pay for subjective outcomes and indirect outcomes like PROs? Here is a typical algorithm for formulary decision-making. I think this is pretty straightforward, and most of us follow a similar process. We start with the initial research for any new drug. We typically review it relative to other alternatives. So any drug review really is a class review. Once we do our internal research and look at all of the clinical trials, we bring in external key opinion leader input. We make our comparisons, and then we present the clinical and financial to the ENT committee or value assessment committee. And then based on efficacy, safety, cost, and other, we make the decision to put the drug on formulary or not. And then if we put it on formulary, what tier? And then does it require or necessitate utilization or application of utilization management, things like prior authorization and step therapy. Looking forward, the role of pharmacy will become more prominent as healthcare reform unfolds. Pharmacy is being forced out of its silo into the care team. We are significantly focusing on de-siloing medical and pharmacy. And as we've seen, pharmacy is now driving a lot of the overall cost. New models of reimbursement, things like accountable care organizations, will continue to require more of this integration of medical and pharmacy data. Interestingly, physicians can no longer be agnostic to cost. They also have to pay attention to cost. Historically, they would look at whatever was best for the patient clinically, and cost didn't factor into the equation, but now it is factored into the equation. So even physicians are looking at cost. Aggressive management of the drug benefit in the pharmacy network will be critical to the ability of payers to provide affordable access to drugs. So things we're looking at include narrowing pharmacy networks, utilizing more clinical programs like medication therapy management, and then using trend management tools for specialty pharmacy drugs because of the increasing, escalating costs of these types of drugs. So the key here, though, is we really have to have better ways of addressing the escalating drug trends and figure out how we can share risk. In conclusion, managed care organizations can contribute to improved outcomes and reduced costs by increasing the understanding of current therapies, recognizing the potential benefit of future therapies, and then developing an understanding of hyperkalemia and therapy options, and then having appropriate benefits and appropriate utilization management controls, and being the quarterback with all of the different stakeholders involved with treating our patients. So this concludes the presentation, and we will now begin the live Q&A session. First one, Dr. Matera, let me start with you. The question is around what is the role of the newer agents in the acute setting, and how do you think they'll be used relative to, say, insulin or other kind of standard of care in the acute setting?
Thanks, Dr. Dunn. Also pleased to be with you guys today. That's a very good question because, as we talked about during the presentation, there are several factors that you want to look at clinically when you're dealing with hyperkalemia. The first and the most important is redistribution, especially if you're starting to see EKG changes. And that's where insulin and calcium and those things take a role. The newer agents and also SPS are there more for elimination. So the newer agents are not approved in the acute setting as of this time, although their mechanism of action and their onset to action are pretty good. They're still not approved for that. So insulin, dextrose, bicarbonate, calcium are still primary importance when you're stabilizing the cardiac membrane. But then if you want to start to eliminate the drug, that's where these newer agents come in. And I can't stress enough that the older agent, SPS in particular, really has a lot of issues. So in the acute setting, we're not looking at these agents just yet. I do think we'll see some research on them in the future. But for right now, they're a very useful adjunct in controlling hyperkalemia.
Perfect. So is it fair to say that hyperkalemia will be acutely treated and then maybe these other oral agents will be maybe prescribed chronically upon discharge as more of a kind of a maintenance control. Is that kind of where you see them fitting in?
That's where I see them fitting in, and that's where I primarily use them in my practice.
Yeah.
I've been very successful over the last year or so in using some of these agents and maintaining, in particular in my chronic kidney disease, nephrotic syndrome population, maintaining their RAS inhibitors, which we all know are so beneficial in those disease states. Then you add on the whole spectrum of congestive heart failure, where again we know agents that are prone to hyperkalemia can be used. I find them to be very useful in that to try to maximize the therapy. And also with the advent of sacubitril and valsartan combination in congestive heart failure, as we saw in the Paradigm trials, it's going to be very important to continue to use these agents. And the limitation of hyperkalemia, we can really deal with that at this point in time.
Perfect, and that's super helpful. And I think just a couple kind of pair comments on that. It first of all brings it brings up the issue of if one of these newer agents is started upon discharge, then we have potentially some coordination of care, continuation of care issues, where we need to make sure that if we have a prior auth or we have any other kind of formulary issues going on with these agents, that we have that process worked out, so that there's a continuity of care there. And then the other comment was getting back to SPS, is that it does have some limitations, and I think there are still some payers who, because of the cost of SPS, are maybe looking to require that use before allowing the use of some of these newer agents, which I think are clinically superior. So if that's the case, I would encourage you to kind of take a look at those edits and policies and kind of reevaluate those. But you kind of hit on this, but maybe we can expound on it a little bit. And the question is, more around the data of using, say, Patiromer with the RAS inhibitors, the ACEs and ARBs, for CHF patients looking to control potassium. And I think intuitively it makes sense that we need to control the hyperkalemia so that we can maximize the dose of the ACE and ARB so we get the cardiovascular benefit. But can you comment on, what kind of actual data we have?
Yeah, I think that, when you look at these agents, that it's just the evidence is overwhelming that these agents help improve quality of life, reduce readmissions, all the things that we're trying to do with the triple aim and as we move into value-based care. And to just have something like hyperkalemia, notice where we start to then taper down or adjust these medications, it's often counterintuitive to what we're trying to do with them. So I think that having this in our armamentarium, and I do feel that, you never want to add another medication, but I feel so strongly about the benefit of the RAS agents that I would rather try to maximize those doses and add something to help control the potassium. And in my experience, I've had some very, very good luck in maintaining normokalemia in our patients to allow the use of these agents. So I think this really does change the playing field a little bit when it comes to maximizing our therapy. If you recall the one slide that I showed, a very small portion of our patients are on maximal therapy. So I think that this does help.
Yeah, I totally agree. I mean, we have to maximize those agents in order to get the CV benefit. They're tied to quality metrics and everything else. So, that's again something for us to look at is, the dosing of the RAS inhibitors. I do think that there was, when Patiromer being the first agent came out, I think there was some concern initially that there might be some uptake of Patiromer as almost like a prophylactic therapy in patients on an ACE or an ARB, and that hasn't been the case, and that's not the role of this agent. It really is in patients who are having hyperkalemia who are at risk. So I think the utilization has been appropriate. So again, that's something for us probably to take a look at again, is our policies around the newer agents, and then our programs to maximize the RAS inhibitors. Dr. Matera,
I couldn't agree more.
Perfect. There's a question around the use of the newer agents in the geriatric population. Is there any data to indicate that efficacy or safety may change in the geriatric population?
No, I don't think there's any specific therapy in that, but we always have to remember, and you know this as well as I do, and probably even more so, in our patients who have polypharmacy, there's a lot of different issues that can occur with that. So I haven't seen a decrease in the efficacy of it. Certainly we have to watch how it's dosed in accordance with other medications to avoid counteractions with certain medications. And you just always have to remember the comorbidities that our patients have. But as far as the efficacy, I've found it to be very efficacious, and I don't see a major issue in the geriatric population. There have been some very scant case reports with people who have other underlying GI issues that affect absorption, but in general, I find them to be very well tolerated. And you know, the most important thing is they really get to that goal. They really get down into the normal kalemic range. So I don't see any issues myself with the geriatric population.
And I agree. You know, the data doesn't seem to indicate that there's any difference. But you know, again, would agree and kind of make a plug for payer programs is that these the geriatric population by nature is going to be on more medication. So you mentioned polypharmacy. They have other comorbidities. So it's a population that we do need to be managing a little bit differently. I think irrespective of the Patiromer, I think the efficacy and safety of Patiromer doesn't change, but there are other issues in that population. So I think I totally agree with that. So I think here's a good question around the labeled requirements of dosing these agents separate from other medications. So the potential for drug interaction, and again, I think this is an opportunity and a responsibility that we have as providers and payers is to counsel and to manage that. So again, a lot of these patients will be in our care management programs and our medication therapy management programs. So whenever we see patients who have hyperkalemia or who are on RAAS inhibitors, who are maybe even in the hospital, that we need to make sure that we are continually educating about that and setting expectations and reinforcing compliance.
Yes.
If you have anything to add to that, Dr. Matera, from kind of how you address that issue in clinical practice.
Yeah, I think as a nephrologist, I've been involved with sort of a dialysis-based accountable care organization called an ESCO, an end-stage renal disease seamless care organization. And one of our big components of that is an MTM program. And it is absolutely beneficial because oftentimes if our patients get hospitalized or they come out, or when we do a pharmacy-based review with our pharmacist, we find so many contraindications with our patients, not even talking about just Patiromer, but other agents that these patients should be on. So I think it's very helpful to undergo that. I think it's a very, very important part of the coordination of care in these patients. Perfect.
So here's a question I'm going to direct to you. And the question is, are there any behavioral or mood indicators of hyperkalemia?
Yeah, I don't think that, I haven't seen any specifically related to hyperkalemia itself. What we do have to remember again is that these patients oftentimes have other comorbid conditions. Many of them may be on different medications. All of those things can affect mood. Certainly we have to remember the mental health in our patients, not just the elderly, but all of our patients, and address those needs. You know as well as I do, Dr. Dunn, that mental health is oftentimes very overlooked here. So as far as mood issues with the actual electrolyte disorder, not so much. But I would certainly look to those patients, make sure that we do a PHQ screening on them, make sure we identify any cognitive defects that may be starting in our patients. Look at their memory type issues. If we do that, we can remain pretty strong with these patients. But the hyperkalemia itself, I haven't seen much in the way of mood effects.
Yeah, neither am I, and I agree that those types of things though may impact adherence and compliance and education levels and other things, but not necessarily the disease state. So I think I'm going to try to squeeze one more question in, and then we'll wrap up so that the audience has time to do the post-testing evaluation. So the question is really around comparing the two newer agents, sodium zirconium, cyclosilicate, and Patiromer. From a clinical perspective, is how different are they? And, is there a population where one may be more effective than another? So maybe Dr. Matera, you can start.
Yeah, I mean, if you look at some of the adverse effects in the studies that we described, there are a couple of subtle differences. The one I particularly always talk about is the hypomagnesemia. In the zirconium studies, you didn't see that reported as much. I don't know if it was just a lack of the study or whether they don't see as much of that. But you also have to remember that a lot of these patients are on proton pump inhibitors, which can also predispose them to hypomagnesemia. So I think the efficacy of the agents is very similar, and I wouldn't see the one particular use of one versus the other, but I do think we have to pay attention to some of the side effects, and I think that's where the difference comes in. I think the key on these is whether or not we will actually see some issues in the future where one of these will be approved in the more acute setting. That's a very interesting topic that I think we need to pay attention to as time goes on.
Yeah, good point. Yeah, I agree. I think that right now most payers are probably handling these similarly. We're still trying to evaluate, what these subtle differences in onset, potential drug interactions, dosing, et cetera, mean. But I think pricing is still kind of up in the air as well.
Yes.
My parting comment will just be, I think some of the concerns initially that there was going to be overuse of these agents or inappropriate use haven't really turned out to be well-founded. They definitely play a role in therapy. There is a huge unmet need given the limitations of existing therapies. So we should be focusing on our MTM programs and our opportunity to educate and improve outcomes with our patients, especially, in my opinion, the patients who are suboptimally using the RAS inhibitors.
Yes, I agree, and I think that really brings into play a whole host of factors that are going to be so important to us as time goes on in value-based care.
Perfect. So, Dr. Matera, thank you very much for your participation in the Q&A section. And again, please take the time now to complete the post-test and evaluation form. And I really would like to thank everyone for joining us today, and hopefully you found the program valuable and enjoyable. Have a great day.
Yep, thank you. Have a good day.